A 10-month-old, male German Shepherd dog with a history of non-weight-bearing lameness of 1 week duration in the right forelimb was referred to the veterinary hospital for evaluation. On physical examination, pain response was elicited on palpation of the right humerus. Radiographic examination revealed areas of increased opacity in the medullary cavity, and laboratory abnormalities were absent. The veterinarian's first clinical suspicion was panosteitis, one of the most common causes of lameness in young, large-breed dogs. It's a painful, self-limiting developmental orthopedic disease of unknown etiology that carries an excellent prognosis. Panosteitis affects the bone marrow tissue in the medullary cavity of long bones, replacing adipocytes with fibrous and bony tissue. The most affected bones are the humerus, ulna, radius, femur, and tibia, but metacarpals and metatarsals also have been reported. Pathological changes typically regress within 60 to 90 days but may persist for up to 190 days. The cycle begins with the exudation of protein-rich edema fluid around small-caliber blood vessels in the adipose tissue of bone marrow. This process occurs near the nutrient foramen in the diaphysis of long bones, extending into the metaphyses. The edema fluid dissects between cells of the fatty marrow, stimulating the proliferation of reticular fibroblasts. As these fibroblasts infiltrate the fatty marrow and organize the edema, they undergo bony metaplasia and begin to form woven trabecular bone. The individual bony trabeculae then increase in thickness, merging with the inner cortical surface. Discrete periosteal proliferation may also be seen. Pain associated with the condition may be linked to increased pressure in the medullary cavity and the stimulation of pain receptors in the periosteum. Regression of the lesions begins when congestion and edema subside. Osteoclasts gradually remove the newly formed trabeculae from the medullary cavity, as they serve no biomechanical purpose. The pathological process eventually regresses to normal or near-normal architecture. The etiology of panosteitis is currently unknown, despite extensive research on the topic. Several theories have been proposed, and here is a summary. Bacterial infection. Streptococcus-induced osteomyelitis was initially proposed as the cause of panosteitis. However, studies failed to isolate bacteria from tissue samples and antibiotic therapy proved ineffective. Viral infection. A viral agent was suggested due to temporal associations with the use of live distemper vaccines and the manifestation of panosteitis. Viral infection could contribute directly to bone inflammation and necrosis. Viral-induced immune responses could dysregulate normal bone remodeling processes. Induction of lesions similar to panosteitis was observed in dogs, following the inoculation of medullary aspirates from panosteitis lesions. However, bone marrow samples from dogs with panosteitis did not cause any cytotoxic effects on kidney cell cultures, which would be expected if the cells were infected with canine distemper. It's speculated that host response to inoculated foreign material likely caused the panosteitis-like lesions. Genetics. A genetic etiology was suggested due to a higher incidence of the disease in breeds like the German Shepherd. However, the condition is known to affect dogs of all breeds. Hemophilia A was suggested as a cause of panosteitis because of concurrent occurrence. Hemophilia-associated deficiencies in blood clotting factors could impair the normal process of bone healing and repair following damage or inflammation. However, panosteitis frequently affects dogs without hemophilia. Endocrine dysfunction was suggested due to temporal association of panosteitis with the first estrus in female dogs. Estrogen influences bone formation, resorption, and remodeling, so fluctuations in estrogen levels could affect bone physiology. However, panosteitis also affects males. Dietary. A possible association between high calcium and protein diets and an increased risk of panosteitis was suggested. Elevated levels of calcium could disrupt the balance of mineral metabolism in growing puppies. However, conclusive evidence is still lacking. Other factors: stress, vascular anomalies, allergy, parasite migration, and autoimmune reactions following viral infections have all been proposed as potential causes, without conclusive evidence. The etiology of panosteitis is probably multifactorial and involves a combination of factors rather than a single cause. Panosteitis typically presents with an acute onset of lameness ranging from mild to moderate, although severe lameness can also occur. The duration varies, with episodes lasting up to 14 days and occasionally extending to 3 weeks. Rest or exercise does not alleviate lameness. The initial episode often affects the front leg, followed by the rear leg, before potentially returning to the front leg. This pattern is described as shifting leg lameness. A concurrent decrease in appetite and activity may also be observed. Panosteitis typically manifests at a younger age, from 5 to 12 months, with initial onset being uncommon in dogs over 2 years old. However, it has been reported in dogs up to 5 years old. While it can affect dogs of any breed, large and giant breeds are notably overrepresented, including but not limited to German Shepherds, Great Danes, Doberman Pinschers, Labrador Retrievers, Golden Retrievers, and Rottweilers. Males are more commonly affected than females, and the latter frequently shows clinical signs during the first estrus. Diagnosis of panosteitis is made primarily via deep palpation. Pain responses ranging from mild to severe are elicited by deep palpation of the affected bone. While radiographs are recommended for confirmation, they may not show any changes until 10 to 14 days after the onset of clinical symptoms, and there's often a weak correlation between the severity of clinical signs and the radiographic changes. The lesions observed in radiographs are patchy, irregular, and ill-defined areas of increased medullary opacity in the diaphysis and metaphysis of long bones. Discrete periosteal reactions may also be present, usually smooth and laminar in appearance. Treatment of panosteitis is primarily supportive, focusing on pain management with nonsteroidal anti-inflammatory drugs and oral analgesics. The prognosis for panosteitis is generally good, with spontaneous recovery expected within several weeks. Relapses are possible but also self-limiting. Thank you for watching the video. See you next time.